Hi, good evening. I will be presenting for Advanced Clinical Practice. This is HMP number 2. Chief complaint for the patient, she is a 30-year-old female that is level 1 trauma, status post-rollover, high-speed accident with prolonged extraction. Patient is unconscious with a GCS of 3. Patient has been noted with a right-sided face laceration, abdominal bruising, right upper arm bruising, and abrasions, and lower leg abrasions, no other visible injuries. Suspected spinal cord injury. For her history, the patient is 30-year-old female that is status post rollover, high-speed accident with prolonged extraction. She was positive for alcohol. The patient was in the front seat. She was the passenger. As I mentioned before, she was a GCS 3. The accident happened approximately at 8 o'clock. The speed of the accident area was greater than 60 miles an hour. The patient is GCS 3 with normal vital signs per EMS. Upon arrival to the emergency room, the patient continued to be a GCS 3 and was intubated. Patient was found to have step-off in the low thoracic spine and decreased rectal turn during primary survey and was immediately sent to CT for CT scans. The CT scan of the head confirmed cerebral edema with no intracranial bleeds. CT of the chest confirmed linear atelectasis. CT of the face confirmed right orbital blowout fractures, orbital floor defect with 1.3 centimeters of herniation of the infraorbital and minimal protrusion of the right inferior rectus muscle into the right maxillary sinus. CT of the C-spine confirmed unstable posterior column fractures in C2 and C3. CT of the T-spine confirmed flex destruction injury with chance fractures involving T11 vertebrae. And CT of the L-spine confirmed mildly non-displaced left transverse process fractures in L2. As far as review of systems, we were not able to attain due to the patient being intubated. Physical examination, vital signs, heart rate 98, blood pressure 116/60, respiratory 23, Tmax 37.5. She is intubated on ventilator support at 97%. Height is 165, weight 175 kilos. Upon physical examination, the patient is not awake, alert, or oriented person, place, or time. The patient is currently intubated and is not able to follow any commands. The patient has been noted with right-sided face lacerations and occipital bruising. No facial droop is present. Cranial nerves are not able to be assessed due to the patient being administered sedation. Patient's pupils are equal and reactive. However, sclera is noted with subconjunctival hemorrhage. Bilateral preorbital edema is present with bruising and possible deformities as well as to the near area. Ears are proportional to the patient. Cough and gag is intact and present with suction via ET tube. The trachea is noted to be midline and oral mucosa is dry. No lymph node masses are noted. Carotid pulses +2. Patient is intubated with minimal respiratory distress. Patient's chest expansion is symmetrical with ventilator assistance. However, mild crackles are noted with auscultation and diminished to the left lower basis. No wheezing or rhonchi noted. Hypoactive bowel sounds are present. Patient's abdomen is round and soft with no distensions. However, there is mild bruising noted. No hepatomegaly. Patient has a 0-5 strength to the upper extremities and 0-5 strength to the lower extremities. Flack pain scale 0 out of 10. Again, patient is on sedation. The patient is noted with +2 radial pulses, right upper arm bruising, and right as well as abrasions, and bilateral leg abrasions as well. Past medical history, not able to obtain, and also social history. Medications, the patient is in albuterol, NEP treatments, 2.5 every 4 hours. Bacitracin for the abrasions to the face. Chlorhexidine solution for the VAP bundle. Mucosal BID, famotidine 20 milligrams, IV piggyback 12 hours. For pain control, patient will have a PCA. Keppra for 500 milligrams, IV piggyback BID, propofol, standard titrate drip. Allergies, no known drug allergies. The patient's social history that was able to obtain by parents. Patient lives in El Paso, Texas, where she resides with her boyfriend for 3 years. The patient is not legally married and has no children. The patient's mother is the next of kin, is making all medical decisions at this time. The patient is a secretary in an attorney's office for the past 5 years. Patient's baseline consists of being able to perform activities of daily life with no complication or assistance. According to patient's parents, the patient occasionally uses alcohol, but no tobacco or illicit drug use, and no family cancer. Laboratory data, WBCs 9.4, RBCs 5.8, hemoglobin 4.5, hematocrit 17.1, platelets 103, INR 1.3, sodium 141, potassium 3.3, chloride 113, glucose 121, B113, and creatinine 0.6. Imaging, again, CT of the chest confirmed linear atelectasis. CT of the face confirmed the right orbital blowout fractures with the defect of 1.3 centimeters with herniation in the infraorbital fate and minimal protrusion of the right inferior rectus muscle into the right maxillary sinus. CT of the spine confirmed unstable posterior column fractures in C2 and C3. CT of the spine also confirmed flexion distraction injury with a chance fracture involving T11 vertebrae. CT of the L spine confirmed a mildly non-displaced left transverse process fracture in L2. So assessment and plan. Assessment and plan of number 1 would be the spinal fracture, which IDC code would be IDC point S12.1, ICD S12.1, ICD S22.802, ICD point S32.02. And this would be for spinal fractures. Again, spinal fractures, you do have a chance of having stirring sensation and other body functions below the site of injury that can be affected with spinal fractures. CT of the spine, as mentioned, confirmed the C2, C3 fracture. The T-spine would be the T11 vertebrae, which would be the ICD S22.082, and the non-displaced transverse process fracture in the L spine, L2, would be the ICD S32.02. For plan in this assessment would be, of course, admit the patient to intensive care unit, consult neurosurgery, full spine precautions, spinal fracture protocol, which would include a rectal digital exam every shift, C-collar in place, neurochecks Q1, we will hold the Lovenox, add anticonvulsants, Keppra, 500 milligrams IV piggyback, BID. We would have a VT prophylaxis, bilateral SCDs, Foley catheter placement for strict eyes and no count, GI prophylaxis, famotidine 20 milligrams, pain control, acetaminophen 650 every Q hours for pain levels from 1 to 4, fentanyl 50 mics, IV push every 2 hours, fentanyl 100 mics every 2 hours for pain levels 7 to 10. Bowel regimen, Docasset 200 milligrams BID, and possible to go to the OR for the C2 and C3 laminectomy, as well as the other fractures, spinal fractures that were involved. We also have a family conference for updating on patients' prognosis and possible quadriplegic status. For assessment number 2, would be the orbital fracture, which would be ICD point S05.8, according to Friedman, H. 2011. The most destructive types of ocular injuries are high-speed motor vehicle accidents in which the patient was involved in. CT of the face did confirm the right orbital fracture blowout, in which it did have a 1.3 centimeter herniation in the infraorbital fate and minimal protrusion to the right inferior rectal muscle and to the right maxillary sinus. Patient was also noted with subconjunctival hemorrhage and bilateral edema and bruising. As far as the assessment plan, we do need to consult OMFS, have the patient's final on sinus precautions, no NG or KOFID to be placed, keep the patient in PO, and possible OR for the orbital and right maxillary repair. For the patient, last assessment would be for assessment 3, which would be pulmonary atelectasis. It's ICD code .S27.30. The CT of the chest did confirm linear atelectasis, and according to the Mayo Clinic disease and condition, it is a complete or partial collapse of the entire lung and area of the lung bruising to the lung tissue itself. Upon examination, patient is noted to be intubated with minimal respiratory distress, minimal crackles upon auscultation, and diminished breath sounds to the lower left lobes. Plan for this assessment would be to continue to have the patient intubated until further notice, especially if the patient is going to the OR. To continue the ventilation settings, right now the patient is in SIMV, rate of 12, tidal volume 500, pressure support 10, PEEP 5, and if FiO2 is to be weaned as patient is tolerated. 3, to keep saturations above 92%. We do have the albuterol neb treatments Q4. Propofol is also to be ordered while the patient is intubated. Thank you very much.